Então, boa tarde a todos, né? Nós vamos dar início aí à reunião científica da UTI Pediátrica do Hospital Universitário da USP. É uma reunião especial, né? Que nós temos aqui o prazer de receber o professor Lurin, que é professor de terapia intensiva pediátrica da Universidade de Zurique, chefe da UTI infantil e neonatal do Hospital Infantil da Universidade de Zurique, e ele é uma referência internacional em sepse, lidera pesquisas em sepse, infecção, inflamação em crianças criticamente doentes e atua em iniciativas internacionais como a Pediatric Surviving Sepsis. Eu acho que é especial porque a gente está tendo a oportunidade de receber o Lurin no mês de setembro, que a gente trabalha para aumentar a consciência, a conscientização em relação à sepse, né? Diminuir a carga da doença, e uma grande oportunidade também, porque nós, no Brasil, estamos começando aí algumas UTIs a trabalharem no ensaio clínico randomizado junto com o Lurin e com a Universidade de Queensland. Obrigada.
Prezada Daniela, prezada Andrea e caros colegas, agradeço muito a oportunidade de ser aqui e, deixa eu ver, ainda lembro um pouquinho de português, mas infelizmente não o suficiente para apresentar, e que são mais ou menos 20 anos que eu trabalhei como estudante nesse hospital Recife, o Hospital Barão de Lucena, não tinha muita oportunidade depois para visitar o Brasil, e agradeço muito essa oportunidade agora. Mas nos 10 anos passados que nós outros começamos para trabalhar juntos, ou que eu conheço também a Flávia Machado, o Cláudio de Oliveira, outros, eu fiquei muito impressionado do trabalho passando no Brasil, sobretudo no filo de sepsis. Então, muitas graças por também this friendship. Oops, let me see. E como a Daniela já disse, que a gente trabalhou junto com a International Pediatric Sepsis Definition Task Force. Isso é uma foto em Salzburg, antes do Covid. E a Daniela, o Cláudio, que fica lá por cima, por la esquerda, que estava um pessoal essencial para o que a gente acabou lá. Okay. If it is okay, I will talk in English. If you ask questions, it's okay in Portuguese. If not, I tell you. Is this better? Oh, yeah. If it's too fast, please tell me. What I put together is, because Daniela said that people here will be mixed of pediatric residents, ED residents, ICU residents, consultants. So I put together a bit of a mix, which starts with some of the basics first, how do we recognize sepsis, what do we do first, but then as well, what do we do if things fail? Yeah, okay. I worked in Australia for 10 years and now in the last 5 years in Switzerland. And what I realize is that sepsis, it's a problem everywhere. And sometimes people from different countries, they think, well, they have so many resources, they have solved it, but it's not true at all. And interestingly, I think we all struggle with the same issues. And so let's try and pick out, some of these. This is an example of a child that was referred to our unit, a few months ago. So I'm not sure if you can read it well, but this is a previously fully healthy girl that came after an elective tonsillectomy to a regional hospital where usually they actually don't care much about children. They have no ICU, they have, some pediatricians, but it's a very small. And things seemed really completely uneventful. But then actually the first evening she was getting more tachycardic and started needing oxygen. And so they went to the bedside, they had a look at her, and it was interpreted that just the NLG was insufficient. So she got what probably most of us would do. She got some increased analgesics. And as you know, what then happens in hospitals where you do not have 24 hours specialists, it's quite different at night. people may not be there, or the people that are there are quite junior, or they may not necessarily have a lot of backups. And often as well, in surgical kits, in daytime, you have someone that knows the child, but at nighttime, actually, no one has any idea of the child because there may not even have been a proper handover. And actually, this is that then what happened. So she became more restless. And interestingly, when you talk to people that see children that have died with sepsis and they say they were restless, they usually think, well, they were still in good conditions because, they were fighting. But actually, they don't realize that probably they already had a degree of confusion and septic encephalopathy, which made them be irritable and less, a 7-year-old child actually should be more, cooperative. And so at night, this Reg, who was a first-year Reg, he called the surgeon. He said, something is worrying me. But he called the surgeon was an ENT surgeon. So the ENT surgeon thought about ENT problems. And so, is he bleeding? No. So then it's probably pain, right? And the blood pressure was documented as, stable. And always in ICU, when at the handovers, when the registrars, they say the patient was stable overnight, the blood pressure was stable, I always say, I don't know what that is. Because if a patient, if stable, then probably the child does not need to be in ICU. But in ICU, I don't know what stable is, because I'm often wrong when I think, someone is stable. But then, so at 48 hours, and you can see the trends overnight. So you can see it overnight, actually, the heart rate was going up, up, up. You can see the saturation. They don't fall below 90, but they fall a little bit, even with oxygen. She becomes more dyspneic. You can see the respiratory rate, on the bottom, which goes up. And then pretty much at in the morning, 8:30 in the morning, they make a MET call. Now, why does this happen at 7:30 in the morning? Shift change, right? So, it's one of the most overlooked features of recognizing sick patients. You just change the shift. And then the new shift realizes that what has been going on the last 8 hours is actually probably dangerous to the patient, right? And so they call a MET call. At this stage, the girl is really going downhill really, really quickly. They struggle to maintain the oxygenation. Again, you can see the blood pressure is still stable, so to speak, but cap refill is long. Glasgow Coma Scale is documented with 15. And again, this is where maybe what you see on the paper does not match what you see in front of your eyes. And you can see the blood gas with, very high lactate. So they prepare for intubation. How would you intubate this patient? How would you stabilize the patient for intubation? What is your procedure here? Yeah. So what would you give, or? Yeah.
Depending on the response to fluids, he has a prolonged capillary refill.
Yeah.
And with rapid sequence intubation.
Okay, so this is very good for those that have not heard it. So Andrea was essentially saying, we first need to improve hemodynamic support for this child before intubating. But this is an intensivist thinking. If you're in a small hospital, an anesthetist will come to the bedside, and an anesthetist that does not often look after children will first worry about the airway. And so what they will do is they will give oxygen, they will give something to sleep to make sure the patient is deep enough, right, to not have any laryngospasm, and intubate. And hemodynamics come later, right? And so this girl actually arrested on intubation. They started CPR. They did an X-ray then as well, which shows quite extensive effusions. And unfortunately, she was brought to us under CPR and then passed away. And in the postmortem, group A strep sepsis grew, right? And so to just show, this is Zurich, very small country. Traffic is not comparable with Sao Paulo. You could essentially have brought this child by bicycle to the hospital, and we lose children with this, right? And so, what can we do to change this? And overall, I see still 3 main issues. I'm not talking about settings where healthcare is so reduced that some basic healthcare actually makes the biggest difference, like in Africa. But I think what you have in Sao Paulo is very, very comparable to many other places in the world. But first question is, how can we recognize sepsis in children? And actually, what do we mean with this? The second point is, how do we do the initial resuscitation the best way? And so these are basics: antibiotics, fluids, inotropes. How do we do this best? And then, of course, and this is less relevant for emergency department, but very relevant for ICU, what do we do with the children that come to our unit that have had all the things before and they're still really, really sick, right? Okay. And so can I just ask to get an impression, who is working in ED here? And who is in ICU? And general pediatrics? Okay, and those that put not up the hands are with the mix, I assume. Okay, yeah. Okay, no, that's good. Yeah. So feel free to interrupt, but we'll try and go through these points, and then we can dwell on some points longer, right? So I thought if this is okay for you, but I'm happy to change. We start a little bit on epidemiology, then how to recognize shock, and then some of the basics, fluids and inotropes, then which inotropes, and then move more towards what can we then do. Some of it actually is more housekeeping, but some of it are more adjuncts, down even to ECMO. Do you have in Sao Paulo, is it only cardiac units that offer ECMO, or can you in principle put children?
Our pediatric hospital there has ECMO for hemodynamic support and respiratory support. It's the Sabará Hospital, the person that talked to you, and they have ECMO outside the cardiac.
Yeah.
It's a private hospital.
Okay, so sometimes you need it, but to be honest, you need it in less than 100 patients, 1 in 100. So let's make sure you do the 99% well, then you may actually not need that 1%. Okay. So as Daniela mentioned, we work together on the Surviving Sepsis campaign, and I think in February next year, the new iteration of this will come out, and it's planned that the pediatric comes out together with the adults, which I think will help too. We can't tell you much details now, but what remains a problem is, I think in there are like 77 recommendations. Out of these recommendations, most are weak. Are you familiar with the grade system on the strength of recommendations? Okay. And actually only one recommendation is based on high-grade evidence. And we're going to talk about this. This is actually the only recommendation where we pretty much went against the evidence with what we recommend, okay? So this just shows you how our field actually is still struggling to produce evidence. And if you think how many sick children there are around the world, and a child now coming to your ICU will have a life expectancy of probably 75, 80 years. So if we could do a better job with what we do for the society, this would obviously make a huge difference. And so we do need research, and we do need trials. We're going to, talk about that a bit. Huh? But I think what's important when people that work in different fields come together, so from emergency or from ward or from ICU, it's very important that we realize that the pre-test probability is very different. Are you all familiar with pre-test probability? Okay, something people often don't talk about much, but it actually has a big impact on how you make decisions, right? Because in medicine, in acute care medicine, we often need to make decisions without knowing for sure if this is correct what we do or not, right? As opposed to, let's say ambulatory polyclinics where you can just wait sometimes. And so the pretest probability that is actually what is the likelihood of my patient, and then you combine this with your assessment of the patient or maybe some lab tests is really important. And so if you look at, sepsis in children, it's it's a very big funnel. And this is really different from adults. If you do adult emergency care in large hospitals, actually the mortality is quite considerable. They're really sick. You have CPRs, all of this happening. In children, South America may be a little bit different in some places, but still the acuity in pediatric EDs is much lower than in adult EDs, right? And children flog our emergency departments, as you know, with fever, cough, pneumonias, milder infection, viral infections. So it's really hard to tease these out. But at that stage, the mortality is very, very low. So most children that you see there, they actually may not have sepsis. Which means that in some settings, like in the US, for example, a major preoccupation now is how can we be quick in treating sepsis, but avoid using too much antibiotics, okay? If you work in a setting where actually the problem is that children are recognized really late and they don't have access to antibiotics for a long time, then maybe your pretest probability is different from, let's say, Philadelphia. Because maybe what's most important is to get in antibiotics quickly, right? But this can depend a lot on the site. Huh? But then actually when you come towards sort of children with sepsis, septic shock that come to ICU, your mortality goes up quite considerably. Then you're somewhere between 10 and 25%. That's not much lower than in adults, okay? In the past, people said always, well, sepsis in children, okay, it's a problem, but they're not as sick as adults. Well, this is wrong. Children with, this means that 1 in 5, 1 in 6 children will die. Even in settings where you have ICU, where you can do pretty much all of this. And this means as well, this is the mortality that the child that has received antibiotics, fluids, and you started inotropes, if this child is still in shock and not improving, this is the mortality this child has, right? Then you're all of a sudden in sort of 1 in 4 children that may not survive. And of course, if you then come to refractory shock, ECMO need, you talk about much less. The problem is as we go along this axis, it gets harder and harder to have any evidence for what we do. And so what I will try and talk you through is a bit, in the absence of robust evidence for quite a few of these interventions that we do, how can we still make decisions based on best judgment, for the patient? Huh? Is that okay? Okay. If it's too fast or too slow, you tell me. Okay. Then, with Daniela, we've published these papers in JAMA to say actually what is sepsis. And these are just the codes if you want to read them. But I think what's important is the 2005 previous criteria for sepsis, which still used SIR, so systemic inflammatory response syndrome. Any child pretty much that had a fever would then qualify for sepsis. And it created problems because no one used it that way, right? And we know nowadays that pretty much any child with bronchiolitis, will have a bit of a fever and will have a bit of tachypnea and tachycardia. And so SIRS criteria on themselves, they're not discriminative of a child, which is sicker by themselves, right? And so one of the pushes behind developing the Phoenix criteria for sepsis, which we published last year, was actually what are objective criteria that can distinguish a child with infection that has a much higher risk of mortality compared to any child with infection. And can we not just say, Daniela and me, we sit together and we write up something and then say, this is how it is, but then we do this in a data-driven approach using data from very different healthcare settings. And so the database which was created for this included 3.5 million children. This is the largest database ever analyzed for children. Most of these were from the US, that's true, because the US is just way ahead as well of Europe or Australia or South America in terms of use of electronic health records. But only about 10% of cases came from ICU, about 20% from ward, and almost 70% actually from ED settings, so quite diverse. Plus we had data from Colombia, from Bangladesh, from Kenya, from China, so they were smaller, but still they were data set from different parts of the world. And the criteria which resulted, the so-called Phoenix criteria, we're going to talk about this in a moment, essentially what they characterize children that have manifest organ dysfunction, which puts them at much higher risk of mortality, okay? And as you can see here, actually, if you apply the Phoenix criteria to high resource settings or as well to low resource setting, what you can see actually, of course, there's a difference in low resource settings. So children with suspected infection are more common. It's about a third. And then actually out of those, the proportion of those that have organ dysfunction in the first 24 hours, so those who have sepsis is higher, is almost double, 15% as opposed to 7%. And there are slightly more that have septic shock, right? But the criteria can be applied through both. But when you look at mortality, what you can see here is that actually once you develop sepsis, so you have organ dysfunction, your mortality jumps up almost by a factor 10. And it's a factor 10 in, whether you're in Sao Paulo or in Chicago or in Zurich or, in New Delhi, it goes up by pretty much a factor 10. So based on this, we can really say sepsis in children, we can measure it and it is serious. And this fits actually with work that Daniela and colleagues have done in Latin America. So this is one of the best epidemiological studies on sepsis in ICU from the last 5 years. And as your study has shown, it's very common. So, it's roughly 25% of patients at any given time point in ICU have sepsis. And about a quarter is in shock, and 1 in 5 will die, right? And this is actually, still quite contemporary, okay? The problem with these criteria is that these criteria tell you who has sepsis, and you can compare it, you can measure it, you can do research on it, but they don't tell you whom can you recognize early who has sepsis, and where maybe, should you start antibiotics, for example. And the reason that we have not published this yet is because it's actually quite hard. It's not that easy to have criteria which work well in different settings to tell you actually whom should you treat. And maybe you remember when adults published sepsis 3, they had the quick SOFA. So everybody familiar with the quick SOFA? Okay, so fast respirate, low Glasgow Coma Scale, low systolic blood pressure. Quick SOFA in adults has an area under the curve in most studies between 0.65 and 0.75. And they said this is much better than SIRS criteria, which had an area under the curve of 0.6 to 0.65. But actually, no one would buy a lab test with that performance, okay? But they got through because they were the first, and probably hypotension in adults is a better marker of being sick than in children, okay? But that's so the difficulty we have for children. So, but how can we do it? And the guidelines, again, I'm really sorry for this, but the guidelines, they don't help. The guidelines tell you should screen. This will look slightly different next year, but actually, they don't tell you how to screen. And so, in ED here, do you have a procedure to screen for sepsis? Or how do you do it? Can I ask?
Sinais de resposta inflamatória sistêmica, mais sinal clínico de disfunção orgânica.
Okay. Okay. And do you apply this to pretty much every patient that comes there, or is this like part of triage, or how do you do it?
Não, quando nós suspeitamos de infecção, aí a gente aplica os critérios de triagem, mas eles não são aplicados para todas as crianças.
Okay, no, that's good. This sounds actually very sensible. So you don't over apply it, but you just say actually if he has a suspicion, you apply it, but then you have, Okay, so I would be very interested actually to look at this, because in Zurich we're trying to implement it, and it's taking some time. So, but if you look at the criteria for Phoenix sepsis, now from an early perspective or from an ED perspective, you have to be actually quite sick, to meet these criteria. No, we don't want to wait for a lactate above 5, or we don't want to wait for these low blood pressures. So what you can see here, these numbers, they work to tell you actually who's at high risk of dying. But that may be too tough to tell you where should you start treating, right? And but what's important is you can see actually the respiratory system. You can just look at SF ratios or saturation by FiO2. So you can do this without a lab test. Cardiovascular dysfunction, you can classify simply by blood pressure or by using inotropes if you don't have a lactate, although many units have lactates. Coagulation is the only lab marker dependent organ dysfunction that you need. But again, platelets actually are quite commonly done around the world. And finally, neurology, as well, is quite easily available. So the advantage of the score is it's internationally harmonized, it's validated, and you can actually, it's redundant. So in the sense that if you don't have one parameter, you can use the other parameter, to count it. And in adults, septic shock includes lactate, but the SOFA score, which you use actually to classify someone as sepsis, does not have lactate. And we think this is actually more congruent, right? But what I think is more important is actually saying that 3 of these 4 organs you can quickly assess based on clinical grounds. And I think this is where recognition should focus on as well. And so in the Phoenix paper, what we said is use whatever works locally to recognize sepsis early. And then if you think this patient could have sepsis, if you think I should treat, use the Phoenix sepsis score to objectify actually what's there. But don't make your clinical decisions dependent on this, right? But how could the early screening look like? And if you talk to different hospitals around the world, you see the whole range from how they do it, right? I think like how we got, what we should still be able is that we're so-called good doctors, that we go to the bedside, we look at the patient, we make a clinical impression, okay? And we work with, nurses that are trained in the same, okay? And you know how this is, 1 o'clock in the morning, there's the experienced nurse that calls you and says, hey, Lorraine, come and have a look at this child. Okay. This is, maybe she has seen something that an AI algorithm may not always see, okay? But we need, I don't know how this is in Brazil, but in Switzerland, in Australia, it is getting more and more difficult that doctors and nurses in training get enough clinical exposure. And our registrars as well, they say that actually the digitalization has not taken, has not made them more efficient, but actually they say it has taken them away from the patient. I don't know how this is here, but there may not only be disadvantages in not having a digital health record, okay? Or when you use one, make sure actually it does not distract you too much from the patient. And then there are paper charts. Maybe this is what you use in ED. This is an example from the UK. The UK has a simple branding for sepsis, the Sepsis 6. These are essentially 6 things that you should do if you think a patient has sepsis. The advantage is it's the same language all over in UK. It's for children, for adults, so everybody, the nurse, the doctor, the physiotherapist, they all learn this. And then more and more systems come, for example, Epic in the US, which have embedded triggers that say, okay, now this patient has a heart rate which has gone above 180, and I see that lactate is increased, so it will trigger. Triggers usually are not smart in the sense that you code something and then it will either alarm or not alarm. And usually the problem when you start this in an electronic health record, it alarms all the time and then no one listens to it, okay? So hospitals go through a lot of efforts to optimize it. But what's coming more and more is that actually then you have a smarter way where this algorithm keeps learning. And this means it's not just learning from the literature, from other publications, but it's learning from your hospital to improve performance from your hospital. And some of the first reports there are quite promising. Interestingly, however, whichever way you go, there are 3 things which really turn up. One is, breathing. Second is cardiovascular system. Third is neurology. And so these are, again, the 3 organs I mentioned before, which are essential for the Phoenix score, but which you can, in a child, as we know, I think that's the beauty of pediatrics, in 60 seconds, you can assess these 3 organs, right? You look at the child, you touch the child, you feel the pulse, you look at the breathing, you look at the interaction. In 60 seconds, you can make some ranking there, right? And so I think we should change how we educate on sepsis. We should explain as well, nurses and doctors and parents, sepsis is actually when an infection that, just is a fever, a cough, a bit a grumpy child, when this changes into an infection where you see there's a shutdown of organs or dysfunction of organs, in particular, that circulation gets compromised, the breathing is starting to worsen, or neurology is compromised. I think this is how we should educate, okay? What then comes in addition to this is you need to think about, does this patient have specific risk factors? Is this patient very young or immunosuppressed? You know, this may just put your alert on different. But the other thing, which I don't know how this is in Brazil, but in Switzerland, we realized we don't really train on this. It's, you know, of course, George Clooney is good looking and everything, but probably the expert of the child is actually the mother, right? And I don't know how well do you train doctors in Brazil how to listen to parents or parents' concern? How do you do that? I mean, it's just a question. It's funny. The longer I do ICU, the more I come to these really simple things. And I think it changes actually quite a lot. And very often when parents lose children of sepsis, they say, actually, I sense this was different from the last time my child has had a flu or a fever, right? And okay. And interestingly then as well, when you look at reports of sepsis screening tools, this is now an example from the UK. So in the UK, pretty much every village has invented a new sepsis warning tool, right? So there's the Bristol one, the Gosh one, you know, everyone. But when you look, sorry, it's a bit small. If you look on the top, you know, what variables do they look at? So they have AVPU. You know, this is alert to voice, to pain, or unresponsive. It's like a mini Glasgow Coma Scale, huh? Do you use this in Brazil, or? Okay. Then I think it's actually more useful than Glasgow Coma Scale outside ICU, but yeah. Then Capri refill time, you have the heart rate, rest rate, oxygen delivery, respiratory distress, cap refill. So you can see these are these basics, and they come up pretty much in different tools, and actually they perform quite well. And now one of the more recent publications comes from the US, and so what they did is the following. They said, and this is now a setting where they have a lot of electronic health records, so they have, you know, hundreds of thousands of data on children. What they said is, okay, can we create like a quick pediatric septic shock as a screening score? And then their thinking behind this was, okay, we think blood pressure and heart rate are important, as is respiratory rate. However, we know that when children have fever, and depending on age, they can vary quite a bit. So what they did is relatively simply, they had a shock index, so heart rate by MAP, which was adapted not only by age, but as well by temperature. Then they looked at age-adapted tachypnea, they looked at prolonged cap refill, and at the neurology. So, you know, physiology, you would say this makes sense, but it was maybe a bit a smarter way to put these items together. And interesting, what you can see there on the right is actually the performance was actually very good in terms of screening. So the sensitivity on the x-axis, as well as the positive predictive value on the right axis. So actually you want to be you want to be in the right top bar, right? So this is like this is Liverpool quick SOFA. This is how Philadelphia does it. And this is what they have. And as you can see, it's very sensitive. And interestingly, this is maybe a bit hard to understand, but what they said is time point 0, this is when the patient met Phoenix sepsis criteria. And as we said before, you're pretty sick by that time. And what they checked, if they looked at the 24 hours before, then at what time point would their score trigger? And what they could show was that actually of course, you take the patients who are not yet super sick when they come to your ED or to your ward. What they could show is that actually you recognize them several hours before. And as we know, if you can start treatment a few hours earlier in a child with sepsis, you know, potentially actually, this may save lives, right? Yes, so this was some of the basics. Any questions until now, or shall we move on? Or yeah.
Vida, você pode voltar o slide? Mais uma vez. Quando eles usaram o índice de choque ajustado, normalmente o índice de choque era systolic blood pressure. E isso é validado, eu usar a pressão arterial média em vez da sistólica?
So you're saying actually this, when we look at shock index, be careful, because actually systolic blood pressure and mean blood pressure may not always be the same. And mean blood pressure potentially is more subjective to measuring problems if you have invasive or non-invasive, right?
Yes.
Yeah. So this is true. This is just how they did it. Yeah.
Mm.
Yeah. What I see what I see quite often, maybe this is different in your unit, I see very often that trainees report on blood pressure means, and I'm usually in ICU more interested in the amplitude. And so the usually the two is, they come and they say, yeah, blood pressure was stable overnight. So I usually have three things to say. One is actually, I don't know what a stable blood pressure is. And then the second one is, I would like to know about systolic and diastolic for the amplitude. And third thing is, if you have a continuously monitored child, we have on our monitors always on the left box the trends from the last 60 minutes. And then you sort of, you want to know what's the trend there. But yeah. Okay. Shall we move on, or? Okay. Is it too slow, too fast? Okay. Okay. Good. Okay. So now let's say we have recognized sepsis, huh? And we have given whichever antibiotic is the right antibiotic to give in your setting. And you give a bit of oxygen, you've done your labs and stuff. But now the question is what you do now, okay? So the guidelines recommend that you give this first bundle with, access, blood culture, antibiotics, lactate, and start fluids and inotropes. You do all of this within 1 hour of recognizing septic shock, up to 3 hours of recognizing sepsis. And after this, actually, there's just this box here on the bottom where you need to think actually of quite a lot of things, right? And we're going to talk about this a little bit later. The problem actually is when it comes to the basics, so, fluids and inotropes, which, to be honest, actually, this only makes sense for children that are shocked. So this is probably one of the first problems with the guidelines, that we say any patient with sepsis, give these things, but actually this does not make sense if you're not shocked, right? So, for example, if you have a child with TBC meningitis, the child will fulfill sepsis criteria because of the neurology. Fluids and inotropes is not going to help at all. Most children with bronchiolitis, actually, or even many children with pneumonia, maybe they're a bit dehydrated when they come, but they may not really need fluid resuscitation. They may not need inotropes, right? But anyway, that's one of the problems, that we give shock treatment sometimes to non-shocked children out of fear that in the past, maybe we've been too slow giving these treatments, right? And the other problem essentially is the paradigm is just keep on giving fluid. And so when I trained in ICU, we actually practiced in simulations that you have, the 50 ml syringe, and you just pump in and you pump out. And in 15 minutes, you want to deliver 60 mils per kilo. And we never succeeded. But, probably it's just way too much, even if we didn't succeed. Yeah. And so actually, and the fluid thing is a bit more tricky, because it's not just the volume, it's as well what type of fluid, the rates, and, even temperature, some people argue actually, may make a difference. And so I came sort of to the conclusion that there is one simple reason that we give a lot of fluid. It's just because we can. It's because it's so simple to give. And so what usually happens is that, the nurse is at the bedside, the patient is sick. Blood pressure drops a bit. So the nurse probably will already give some fluid. Or at least in our unit, the nurses they can decide that themselves. So the first one. And then, okay, the nurse goes into coffee break and the other nurse comes, blood pressure is low, so she calls the reg. And while she calls the reg, who's putting in a line in another child, she will give some more fluid, okay? By the time the registrar comes, it's now 1 o'clock in the morning, it doesn't want to wake up the consultant, says, okay, I'll give some fluid, okay? So by the time the consultant is involved, the child may already have had 40 mils per kilo, okay? It's just so easy, okay? And the question actually is, is this really so easy? The problem is with fluids, you never pay the price yourself. It's the next shift and the patient who will pay the price, never you, right? And so we fool ourselves that we think actually, giving salt to patients doesn't hurt, or that, the FEAST study comes from Africa, it doesn't apply to us, and that we're in ICU, if there's too much fluid, we can handle it, we use diuretics and renal replacement stuff. But I'll try and show you some examples. So this is a trial we did with Kristen and Sai in Australia, which just children were randomized to get 3 types of isotonic fluids. So lactated ringers, plasmolite. Do you use plasmolite in Brazil? Or? Okay. So that's in Zurich we struggled to get it. So yeah. Okay, yeah. So we have not yet received permission in Zurich. Yeah. Okay. Okay, so we use ringer lactate a lot. How often you use normal saline in ICU? Sylvia, yeah. So we still use it quite a lot for all neurotype patients, but we've almost stopped outside the neurotype. But essentially what this study showed is the incidence of hyperchloremia doubles if you use normal saline as opposed to other fluids. And adult data show quite consistently that hyperchloremia is not good, at least not good for the kidneys, potentially not good for other organs, okay? And interesting, this is a study from Yuma Shankar from India, where they compare different types of fluids now with children with sepsis. About 600 kids were enrolled. And what they show actually objectively that at 30 days, they had more problems actually with kidney function if children got normal saline. So, there's a large study going on in the US called the PROM-BOLO study, which is looking at this with, I think, over 8,000 kids that probably next year should come out giving a definitive answer. But at this stage, for children with sepsis, I think quite a lot of signals that point towards rather avoiding normal saline, right? The FEAST study, as you probably know, this was over 10 years ago. What was I think about 3,000 kids enrolled, comparing 10 mils per kilo, no fluid bolus albumin or saline. And as you can see on the top left graph, the mortality goes up already with the first fluid bolus, independent of what solution you use. Now, this is a really, a signal for concern. And how people explain this, they said is, well, in the FEAST trial, they could not ventilate, they could not do ICU. And so actually they could not handle fluid overload. And that explanation probably is true, but it still means, why would we do something that kills patients so often when actually, how sure are we that this is not killing patients in high-income countries too? And so the current sepsis guideline, what you can see on the right side, essentially, depending on if you work in a setting which can offer intensive care resources, you can use more fluids as opposed to not. And I still think this is maybe academically a correct construct of the evidence, but as a clinician, I struggle with this. Because, either these kids in the FEAST trial in Africa, they had sepsis and then we can learn something from it or not. And so to me, this is a real a call for caution. Maybe it should not mean we should never use fluids, because we do not want to under-resuscitate, but we probably should be a lot more cautious. And if we think back of how IV fluids were introduced, has anyone, have you seen this before? Or yeah, so this is Sir Thomas Latte. This is one of the earlier papers in The Lancet, as you can see, almost 200 years ago. And the patient has cholera. Okay. Now, in Zurich, cholera is very rare to be found in ICU. And yet we give a lot of fluid. Okay. And as you can see how he describes, I mean, this is beautiful. If you read this, you want to become an intensivist, right? You sort of, patients are dead and you give fluid and they look fine again. And, in dengue, which you have a lot more in Brazil, dengue may be uniquely sensitive to giving fluid and responsive, right? But septic shock actually can be quite different. And one of the problems is that hypovolemia is usually not a major component of septic shock, or actually it's not that severe. And as you know, except for the rare patient that comes with, hemolytic uremic syndrome with severe diarrheas or other, I mean, they can be, or some toxic shock patients with profuse diarrhea. But the majority of patients, they they have eaten a bit less the last few days, they may be a little bit dehydrated, but actually hypovolemia is not their major problem. And so the problem in children is more that concomitantly they're often vasodilatory in some parts of the body. They have depressed myocardial function. They have some obstructive components as well and cytotoxic components. And if you look at how the cardiac index, behaves as opposed actually to the vascular resistance, what you can see here on the right, traditionally people have made this pattern of, warm shock, cold shock. Huh? So essentially this is, essentially you make a 2x2 table where you have the vascular resistance on the y-axis and your cardiac output is high or low on the x-axis. And then, you get a warm shock where you have high cardiac output, low vascular resistance, and you get a cold shock where you have high vascular resistance, low cardiac output. But what this does not tell you is that there are two boxes in this 2x2 field that you have not spoken about. So one box is somewhat increased vascular resistance, high cardiac output. These are the kids we actually see a lot early during sepsis. We just don't realize it, okay? And then you have the bottom left, which are the kids that have a low vascular resistance and a low cardiac output. These are the children which we lose, right? And these are the children which are hardest to treat because if you give them vasoconstrictors, you may try and reverse the vasoplegia, but at the same time, it may make your cardiac function worse, right? The other thing which this 2x2 table actually fools you is you get the impression these are static patient phenotypes that you diagnose it and then it's going to be like this until tomorrow. But this is not true. Children can move very quickly. In 1 hour, this may be different. And it may be different because of your treatment, but it may be different because of your patient, right? And so giving fluids is a real simplification of the problem. And the issue with fluids is that there's actually quite good evidence. The left one is from India, the right one is from Melbourne data, that with independent of the type of fluid, but 1 hour later, everything is the same, okay? So fluids usually only achieve very temporary improvement of physiology, if at all. But if we say 1 hour later, things are the same, that's not quite true because your fluid is in the body now, right? And one of the strongest signs actually how relevant this can be, and I remember when I read this paper, to be honest, I didn't believe it. And so what they describe here is they compared how fast you give a fluid bolus in India to a child with septic shock. And they compared giving it rapidly or quite slowly. And what they found, as you can see here, is that the kids that got fluids much quicker, more fluids quicker, their oxygenation indices, so actually how good the gas exchange in the lung happened, were substantially lower, leading to more intubations actually in this patient group. So when I read this, I thought it can't be that strong, the effect. But, maybe it is. Because, as we remember, if you, the lungs are the thinnest, how do you say? Yeah, the pulmonary alveoli are the thinnest parts of our body, right? And they're highly vascularized, right? We know that if a child has just a bit of, massive stridor for some time, that, children can within 15 minutes, they can go into negative pulmonary pressure edema. We've all experienced these cases. So, if you push fluid really quickly, actually this can happen. Okay? And interestingly, just 2 weeks ago, we had a child coming into the ICU with a hemoglobin with 50, probably not septic, but I want to tell a different story. That with a hemolytic uremic syndrome. In Switzerland, kids drink a lot of milk from the farm, so we have quite a lot of hemolytic uremic syndrome. And this child was quite sick, and then they tried to put in a large renal replacement catheter. The child was just, I think, 8 kilos or so on, and the trainee that put it in actually got it wrong, and so he was just bleeding, of course, and so the child then became hypotensive and we were called to the bedside while the other consultant actually tried to put in a new vas cath. And initially the team was focused on the assumption that this child now is going into hemorrhagic shock. And so we pushed a lot of fluid in. We gave platelets, I think some albumin still and red blood cells. So this child probably got about 40 to 50 mils per kilo in about 15 minutes, like in the old days of sepsis resuscitation. And within that time, actually, we struggled to ventilate the patient more and more. After blood products were in, the child was spurting pulmonary edema. And half an hour later, with a bit of PEEP, everything was resolved. It turned out actually the blood loss had not been that severe, so we probably overtreated. And essentially, I think what we just overdid fluid resuscitation. And we pushed the child into frank pulmonary edema, within less than half an hour, okay? And to just now put this into context, because his child was weaned and extubated the next day, this was, in hindsight, almost purely iatrogenic, because we made essentially a misjudgment call, right? But this is, I think, again, what is shown here. If we push fluids very quickly into patients, the first organ where it will go are the lungs, right? But the lungs are not the only organs. We've already mentioned the kidneys before, but actually any organ will swell up. It affects the heart, the gut, you have higher risk then as well of translocation. And interestingly, I mean, one of the purposes of resuscitation of shocked children is you want to improve oxygen delivery to tissues, we always say, right? But with oxygen delivery to tissues, what we actually mean is that the oxygen goes from the capillary into the cell, right? And there are two things which drive this. One is the partial pressure gradient. The other thing is the physical distance. Okay, so the more tissue edema you have, inevitably, actually, you will compromise as well, oxygen delivery. And in addition, of course, the swelling and increased venous congestion may then actually compromise organ perfusion, right? Because maybe your systolic blood pressure has been dropping with shock, and your CVP actually now is not 10 anymore, it's maybe 20, and so your perfusion pressure goes down. And there are two organs which don't like this. And the first one is the kidneys, but as well, the brain does not like this, okay? And so it's not surprising that actually consistently across many different studies, the fluid overload in children is a strong predictor of mortality, the strongest signal seen actually in patients with sepsis, right? And so the question is, what can we do different? And in adults now, there are two large trials published, I think a third one on the way, which looked at fluid restrictive resuscitation of patients with sepsis. Interestingly, both studies, they did not show increased mortality, but neither any benefit. And in children, we don't have larger studies yet, but we have some indications. This is an observational study from India, or as well, this is a study from the UK, where they used smaller amounts of fluid boluses, and they could show actually that it is safe. Potentially, actually, some of the outcome markers, such as admission to ICU, length of stay in ICU, are better. And with this, we did a pilot study in Australia, the Respond ED study, where we started early adrenaline peripherally. And what we could show as well, that ED clinicians used adrenaline already after 10 to 20 mils per kilo fluid bolus. There are no complications. But of course, it was more a feasibility study. We cannot comment on the benefits. The acuity in this setting in the EDs was very, very low. There were 0 deaths. And so, but what we could see, and this is what you can see on the top left, is that actually the children that got adrenaline, their heart rate came down faster than in those that did not start early inotropes. And I don't know how this is here, but our ED colleagues often are worried to start adrenaline if patients are very tachycardic, because they say with the adrenaline, they're going to be even faster. And this is just the proof of the opposite. If they're very tachycardic, they probably need some support. And if you give them some support, actually the heart rate may come down. And we're currently actually analyzing data of a similar study, with Viviana Pavlic and Natalia Lopera in Paraguay, who have applied the same cohort to Latin American ED settings, where the acuity is much, much higher. And I can't tell you details, but in principle, the protocol seems to work. Huh? And so what we probably should think more about is that fluid and inotrope resuscitation should maybe not just be a sequential thinking. You know, in the sepsis guidelines, you first give fluids 40 to 60 mils per kilo before you start thinking, and then you start your inotrope, usually adrenaline first, and if that fails, then you think more. So we probably need to think more about doing these things in parallel. Starting with fluid, I think, is not a bad thing, because it can be done quickly, and you know, it always takes some time to draw up an inotrope, okay? And this allows you, while the first fluid goes in, you look at the patient, maybe you do a quick ultrasound, you feel the pulses, and you decide actually on what's next, right? But if the patient is not responsive to fluid, you should be really cautious to just keep on giving the same strategy over and over again, right? And so essentially, and this paper that as well, a number of us were involved, it tries to propose to say, actually, you have 3 possible interventions. You can give fluids to increase the preload, you can give an inotrope, or you can give a vasoconstrictor. Of course, you can give vasodilators too, but if we're honest, we don't use that much in the first 12 hours, right? It's more often. But you need to assess 3 things, not just the blood pressure. You need to think of pressure, filling, and flow. Okay. And so the idea behind this, and this is not a guideline, this is actually more a stimulation to think, is that when you have the next child with sepsis coming to you, assess these 3 aspects. Assess not the pressure, but assess as well the perfusion and the filling. You know, filling, for example, through how good is the gas exchange in the lungs. It's very rare that I have trainees in the morning handover that say, our oxygenation is worse because I actually think, you know, we're fluid overloaded patients. I almost never hear this. Or, you know, the liver goes up, for example. And then actually titrate the next step of your treatment to this, right? These are just the details here. Yeah. So we're now through the basics. Now, do you want to discuss, or do you want to go on, or do you have specific questions, or okay? All right. So the question then is, which inotrope? And the Surviving Sepsis campaign, again, actually does not really tell you which inotropes, but usually they use a map between the 5th and the 50th percentile. However, if you look at different guidelines, this is a real pain. It's not that easy, because different guidelines use different cutoffs for blood pressure. And so I don't know what you use a unit, but it's not that easy, because actually maybe we don't know well enough what's the best. What we know now from large data sets is that, you know, for adults, probably, you know, a systolic around 90 is probably mostly okay, right? And that this probably applies as well to, you know, teenagers or slightly older kids. But for the young ones, we're not too sure, okay? Then the question then, of course, is as well, if you give an inotrope, you know, which inotrope? And for a long time, you know, dopamine has been the main used drug. And actually, thanks to a trial actually led by Andrea and Daniela, you know, this came out of favor. And this is consistent with adult data as well. So since then, actually, dopamine has in most centers been replaced. But the question is, should you use adrenaline or noradrenaline as first line? Can I ask this? Do you have a standard here? What do you start with? Adrenaline, yeah.
We're discussing with our fellows last week that probably we will need to think about it. It's not that one size fits all, not for the first line vasoactive drug. And I used to think that both drugs, adrenaline and noradrenaline, have both effects, vasopressor and inotrope. But if I need a vasopressor, I would use a vasopressor like noradrenaline. But if I need an inotrope, I would use adrenaline. And how I would decide that, I was suggesting them to look at the pulse pressure. If I have a wide pulse pressure, I would use a noradrenaline. If you have a low pulse pressure, I would use adrenaline. Because if you keep them at the low doses, they will have both effects.
Yeah. So yeah, I fully agree with all you said. we don't have the evidence. In adults, there is evidence that noradrenaline is better. But adults may be different in two relations, which are quite important. One is they probably have more often vasoplegic shock than, broader pediatric populations. The issue of myocardial depression is less of an issue for adults. And the second thing is most of their patients are above 65 and have coronary artery disease. And so they don't like inotropy and proarrhythmic drugs, which is almost never a problem for us. So in our unit, we start with adrenaline first, but mainly to avoid that people lose time by thinking what they should use. And we think for EDs as well, it's a bit easier to just start adrenaline. I'm pretty sure that we don't do harm with adrenaline because you have the alpha and the beta effects. But you need to very quickly think through, is this enough, right? And so we discuss in the team as well, you should not keep going up on the adrenaline dose until you're at 0.2. And then you start thinking, actually, once you hit 0.1, you should already say, actually, something may not be working enough here. And if you have a child that's absolutely crap in front of your eyes, sometimes we just start both, straight away. Or vasopressin. Vasopressin, maybe you have seen it in the news, in the journals last year. It's a new, hot, sexy topic, when and how to use vasopressin in adults. We don't really have comparable data from kids at this stage, so we don't. We use it quite a lot, but mainly as a second-line vasoconstrictor. One of the areas where we really lack evidence is what are the best therapeutic endpoints to use. And so essentially the list that you see here, again, goes back to the clinical assessment of the 3 key organs at the bedside. What does your cap refill, your pulse pressure, not just your heart rate, because the really sick kids with sepsis, I rarely see the heart rate coming down a lot in the first few hours. I mean, there are some kids that get sick and you pick them early and they recover quickly. There you see this. But the really, really sick ones, they quite often stay tachycardic for quite some time. And so again, I see a risk here in old recommendations that say, keep on pushing fluid until heart rate normalizes. I see a risk there because the really sick kids, I've never seen a normalized heart rate in the first few hours. But I mean, the magic is how do we integrate these, and we don't really know for sure. I mentioned before already, so that we have this 2x2 table of SVR and cardiac output. And so the first part is easy, but the problem is actually what happens after. These are 2 trials which will come out next year, right? But so now the question is, what else can we do if we've hit that point, right? We've given the basics and the patient is still sick. One is, and this gets us back to the question in the beginning, actually, how can we maximize safety of intubation? And I've seen more kids in ICU die or arrest because of hemodynamics than because of failed airways, which is, I think, a really different situation of the intensivist compared to the anesthetist. We now use video laryngoscopy almost as a standard. We think this has really gotten down our airway manipulation problems more, but hemodynamic stabilization in terms of fluid inotrope support is key. And what we see quite a lot is that clinicians may think the patient is on inotropes and not realize that they have given the order for inotropes, but that maybe the drug is not yet in the child. Either because the nurse is still drawing it up, or because you have all the tubing and the drug actually has not yet reached your patient. So just when you're in that situation, this is basics, but just make sure what fluid rate are your inotropes running, and we recommend to have low dose adrenaline ready as a bolus. So we use 1/10 of a resus dose in such cases. So essentially we take 1 milligram of adrenaline and draw it up in 100 mils of saline. Then you have 10 mics in 1 mil. And so 0.1 mil per kilo is then 1 mic per kilo. So it's 1/10 of a resus dose. And we give this to these kids, a bit like the anesthetists do when they bring unstable children from theater and they say everything was fine and they keep on pushing metaraminol until they, think of PEEP, of course. And I don't know, in terms of sedation, our standard is fentanyl or ketamine with, rocuronium. We never use etomidate, thiopropofol, pretty much never in these cases, sometimes tiny bit of mid-AS. Yeah, I don't know about your practice. Okay, this probably I don't want to go through too much, but actually don't forget the housekeeping. The children with septic shock that, by now this child is ventilated on inotropes in your unit. There are quite a number of basic things that you can actually, miss out on if you don't look well enough. So very often these kids really go into PARDS. So really start to think early about lung protective ventilation and think of actually picking what saturation range do you want. We now base our saturation targets on the OxyPICU trial. So we would usually go for around 88 to 92 saturations in these kids, okay? Then target blood pressure, as mentioned, we're not too sure. Use of ultrasound, there's not good evidence, but probably you should be quite generous. And one of the problems in these kids, in our experience, is often when in the last 12 hours they get more fluid, the kidneys go off, they start having effusions, their gas exchange goes down. When are you how aggressive with other interventions? So, for example, pleural drains, or how early do you go on renal replacement? There are some trials in adults that you may have seen on early renal replacement in septic shock, which had very promising theory, and most of those did not work, right? And in children, the side effects you get from any invasive procedure are probably actually higher, right? So in children, there is no evidence to suggest that going on renal replacement early actually is potentially beneficial. My suspicion is more that reducing the amount of children that may end up on renal replacement by being more cautious with fluids, for example, potentially could be the way to go. And then, remember some basics. We should feed these patients. We should avoid secondary hypoglycemia, and we really need to target, sedation well, right? Steroids, of course, is a big question. And at this stage, the evidence is not there. And actually, there's some data that suggests potential harm, some data suggests potential benefit, and so the recommendation really does not help you. What we know from pediatric trials is that they're all quite small. So now the RESPOND trial will give us some more information than the SHIPS trial will give us certainly much better information. But the next phase of ICU probably will actually have a different approach. Next phase of ICU will think more about which patients are likely to benefit from steroids. Some more recent insights into the biology of steroid response suggest that actually some patients may suffer harm. So if their immune system is already suppressed, if their adaptive immunity is down already, then hydrocortisone potentially could be more detrimental. But at this stage, we have no single simple biomarker that could tell us where to give it. What we know from adults is if you give them steroids, their blood pressure goes up. And in adults, they say it's quite safe. And as in the study, they had shorter duration of ventilation, but interestingly, the same mortality. And so some adults interpret this as saying, okay, this means I can give steroids to all patients, and others interpret it as saying, it makes no difference, right? So we don't know. In our practice, we give hydrocortisone 1 milligram per kilo 6 hourly if a patient is on a deteriorating pattern and has at least about 0.1 of adrenaline, 0.1 of NORAD together. This is not evidence-based. This is sort of a rough, yeah. What do you do here?
We do the same, but with higher doses of noradrenaline and adrenaline, maybe 0.3. We don't have ECMO. So we tend to use a lot hydrocortisone, aiming to increase blood pressure and avoid deterioration because we won't have anything else to do.
Yeah, so maybe you're right. Maybe our threshold is too low. That could be, yeah. And then, of course, the question came, can we have something fancy? The sepsis literature for 20 years has always hoped that there would be magic cures. And actually, the literature has been pretty much disappointing. And so the latest fancy story actually was the vitamin C, for which, we're doing the RESPOND trial. And In adults, essentially, there were some very promising initial data, some first RCTs, which were still promising, but then actually quite a number of RCTs that did not confirm this, and more recent data in one RCT that showed actually potential harm. In theory, it makes sense because sepsis is essentially a massive redox, disease, where you deprive your body. You have a lot of oxidizing agents around you. You destroy receptors, you destroy membranes. So in theory, that would make sense. Hydrocortisone has been shown actually to improve its efficacy in combination. But the practical data actually look different. And the largest meta-analysis in adults actually shows, paradoxically, potential benefit on 30-day mortality, but harm for 90-day mortality. Now, what do you want to do with this, right? And as you can see, the adults were able to recruit, I think close to 10,000 patients on different trials within a few years through different trials to measure this. In kids, actually, we have very little data still. There's an observational match study from the US, which showed potential benefit in terms of reduced mortality, as you can see on the left. We measured in Australia levels of vitamin C and thiamine in critically ill children, and we could show that the sicker they were, the more multi-organ dysfunction they had, the lower these vitamin levels. So, of course, that may mean, you should give them, but of course it could mean as well, this is just a marker of being sick, and you can give it and it does not change anything, right? And so we've designed the RESPOND-PICU trial, which was the pilot trial for now the full RESPOND trial, where essentially time to shock, it was feasible, but time to shock resolution seemed to be shorter if they were in that combination treatment. And then, all interventions essentially, otherwise seemed safe. And so based on this now, currently Australia is running the RESPOND trial, which compares standard care versus hydrocortisone alone versus hydrocortisone with a high dose vitamin C. And the reason that despite the adult data that we said actually we should continue with this trial is that it's possible that children are very different from adults. Their metabolic needs are much higher. Septic shock is something much more dynamic than in adults, and malnutrition is much more common, right? And so we thought this was probably justified despite inconclusive or negative adult evidence to actually say we need pediatric evidence on this. And this is where the trial is at. So as you can see, we're just under 100 patients left to recruit. And we're very excited, thanks to the help from Andrea and Daniela and colleagues, that some sites here in Sao Paulo will join as well on this, right? And now we could either finish and go into the discussion, or I could give a wrap up on ECMO if you're interested, as you prefer. Shall we do a little? Okay. So what I have not shown is if you look at how children die with sepsis or septic shock, it's a very steep curve. So most deaths around the world happen very, very early. And sepsis essentially is a failure of oxygen delivery, right? And so, of course, ECMO is, in theory, an attractive option because ECMO is an oxygen delivery machine, okay? And this is really for this box on the 2x2 table. If you have children where the cardiac output is now dropping and they're vasoplegic, what do you do then? And as I said earlier, 99% of these kids, you usually can turn around or find other solutions than ECMO. But in some cases, actually, you have to think about it. In our case, usually these are the children which are unresponsive to interventions. So where actually the pattern is one of steep decline, where you have echocardiographic indications of poor function sometimes. But in many of these kids, when you look at the echo, actually, they're pounding away. For different reasons. One is that they probably need a cardiac output that is 2-3 times their normal cardiac output in the septic state. But the other reason is they're often a little bit underfilled and they're vasoplegic. So your echo assessment will overestimate actually how good their hearts are. So to be honest, we do echoes in these kids, but if they tell me the function is good, it does not tell you that much. If they tell you the function is bad, okay, then it's a bit like pulmonary hypertension. Like you can't rule out pulmonary hypertension purely on echo always, right? If they've had a cardiac arrest, don't wait for the next cardiac arrest. a child with septic shock that's going down, and if they've had their cardiac arrest, the risk of this happening again, and the next time you're not going to get them back, is very, very high. High VIS score, lactate for me is really as well a marker, lactate that stays high. And the other issue is of course the combination. As mentioned before, actually, when these kids go into bad ARDS, sometimes you have kids where you think the shock, you're really at a low level, but you're just managing the shock, but the child has stopped having urine output, and you're now having sats of 84, 83 with 100% of oxygen. Your vent pressures go up, and you can see actually now you're compromising. So a combination with ARDS as well. The guidelines essentially tell you if you're desperate, consider it. Then in our experience, I think you need to be a really good ECMO center with a lot of VV runs that you can comfortably put these children on the VV ECMO if they're shocked. The reason why I'm saying is that the majority of septic shock with ARDS that go on ECMO, the septic shock is not over when you go on ECMO. And then if you just go VV, it may force you sometimes to convert from VV to VA. Is everybody familiar with VV, VA, ECMO? Okay, yeah. If you have a pure pneumonia and all the rest is fine, of course, then VV is better, yeah. Interesting, actually, if you look at the pooled survival of kids that have been on ECMO, it's roughly 60%. This is almost double the survival of adults on ECMO with septic shock, right? And so it is actually quite a viable treatment. The question is, if you do it, how? The first point is patient selection. So as I mentioned before, I would not use strict cutoffs, but really look at the trends. Comorbidities play quite a big role. Nowadays, some of these kids may be oncologic patients, or they've had a transplant, or something else. So, as I think you mentioned as well, Daniela, today, you see a lot of kids with neurological comorbidities. So, think well if you really want to go through this. But if you do it, in our experience, in younger kids, we're quite generous to go through the chest. This works in services where ECMO is inserted by cardiac surgeons, not by general surgeons. But the point is actually that the flows that you can achieve through neck cannulations in young kids or in teenagers through the groin, these flows are usually just enough to match normal cardiac output. So, 150 mils per kilo. Sometimes you struggle to match these outputs. Kids in septic shock, they may need double this output or more. And so when you open the chest, actually you can use, like in cardiac theater, you can use much bigger cannula, and so you can run much, much higher flows. These are Australian data where this was shown to be beneficial, and essentially we mapped sort of a risk-benefit ratio where you can essentially, it's a bit theoretical, but I think it reflects what we do at the bedside, is that if you think a child has a very high chance of dying, then ECMO actually potentially may confer a mortality benefit. And there's a recent paper from PCCM from the US that has for the first time validated these Australian data. And what they show essentially is that if you go on ECMO for septic shock in children, that the risk of mortality is substantially lower if you use central cannulation as opposed to peripheral cannulation. And this is associated, as you can see on the right, with the amount of flows that you can generate there. People had a lot of fears that then kids would bleed to death. Interestingly, we don't see this as a major problem. And this may have several issues. The first one is we don't see a lot of meningococcal infections anymore. So most of our septic kids, they're pneumococcal, staph, some weird gram-negative stuff, which means that DIC, of course, a lot of these kids have a degree of DIC, but it's not necessarily as bad as we're used to with meningococcal, right? The second issue is that I think cardiac surgery has become just really good handling bleeding. So, you can actually do this. And the third point is that with modern ECMO circuits, we're not as afraid of losing the circuit anymore. So you can actually go on ECMO. We usually give these kids hundreds units per kilo of heparin when we go on. Sometimes we give these kids just half of those. But then we usually would run them at least for 4 hours, sometimes for 12 to 24 hours, even without heparin. Because if you have very high flows, you can actually do without heparin. And so the approach, and in the first few hours, is you replace blood products, platelets, FFP, to have normal coagulation. and you wait with heparin. And then after 12 or 24 hours, you start, right? And this, of course, we still lose children with this, and we don't, it's a selection that we put on. But since we do this, what has changed is that actually our prognostication is not accurate anymore. Because, you know, before, in kids, you don't put on ECMO if they're black. You know, like some of these kids, you feel them and they're warm here, and here it's ice cold already. And on day 2, they still look the same. Often you could reasonably comfortably tell the parents, I don't think your child is going to keep the limbs, right? On ECMO, this is really, your predictions can be pretty wrong. And we've seen kids that over 1 week, actually, you know, this passage from cold to warm, that it really, you know, goes forward. You know, just 2 months ago, same story. A child came from another hospital, crazy doses of vasoconstrictors. Looked like the nurses said on the first day, is this ethical what we're doing here? Are we not going to create a child that actually has no limbs? And the child walked away actually with 0 amputations. They're going back to school now. And so some things change, right? And yeah, so we need to keep an open mind for this. But yeah, so in summary, I hope I've been able to, although we finish with ECMO, this is really not the message I wanted to give, because I think if we do a good job, we probably can almost always avoid it. And key is really early recognition. Remember the 3 organs. How is the circulation? How is the breathing? How is the neurology? And remember that you should train your doctors and nurses, even ask the parents, has something happened in the last 24 hours that would suggest that a child that has an infection has gone from an infection without organ dysfunction towards an infection where these organs start being dysfunctional. Remember, you can assess this without sophisticated tools quickly at the bedside, right? And then if you treat, use antibiotics early, and think more in parallel when you use fluids and inotropes vasoconstrictors, knowing that we don't really know what's the best one, but probably some caution of giving too much fluids is warranted, right? Yes, and with this, you know, we probably should stop. Yeah. Obrigado.
Obrigado, Luring. Pessoal, perguntas, fiquem à vontade. E tem no chat alguma coisa? Acho que... Pessoal de casa, se quiser fazer alguma pergunta. Bom, eu adorei as mensagens. Acho que é sempre importante a gente reforçar aí esses conceitos, e o Luring trouxe conceitos, acho que novos para a gente pensar, né? Ninguém, Andréia?
We should be here longer. I would like to ask you, I always thought about ECMO in sepsis, considering the cardiovascular failure. But you show that there's many other indications for ECMO in a patient with septic shock. Can we go back on the slide of... Pode botar o slide, por favor.
None of these indications is absolute, you know. So you look at the combination. So you may put a child on ECMO with really bad ARDS where the shock is not hugely in the forefront, or the opposite, but it's like the combination. Question always, I mean, ICU is not managing the now, but managing the next 12 hours, right? And so if you, and this is why, let's say, a score probably will never help us enough with that decision making, because you somehow need to put all of these together.
Yeah, that's what I was going to ask you about, the catecholamine refractory. É o outro, Dani.
Oh, yeah.
Não, mais para trás.
You mean,
que tem a tabelinha esse daí,
yeah.
esse aí. the catecholamine refractory shock score. We don't need it because.
I agree.
Okay.
Yeah, I fully agree. It's useless. Yeah.
No, I mean, for us, it's useless because it predicts mortality and predicts the patient that goes to ECMO. And we have to act before that because we don't have ECMO. And I see your indications of ECMO, there are so many more than the cardiovascular failure, right?
Yeah, and the I think for treatment decisions often in ICU happen based on dynamics that you see over time and responsiveness to intervention, and not just on a yes, no, or one threshold, right? And so you need to take that. Maybe you have a child where you have really high doses of inotropes, and sometimes we have really cardioplegic kids coming back after bypass surgery, where you say, I'm using so much NORAD, actually I can't tell the surgeon because he's going to think I'm crazy. But the child is still warm peripherally.
Yeah.
And then you say, well, okay, the VIS score may not reflect that the patient clinically is not doing that bad, right? And your lactate is still okay, it's making some urine. Then I'm much happier to live with really high doses of inotropes. But if you use really high doses of inotropes, your blood pressure is still almost nowhere, and the child has very little clinical perfusion. I would say, I'm completely running out of options now.
Mm-hmm.
Yeah. And this is, is something that papers cannot reflect that detail at the bedside. Yeah.
I don't like to think about the things that I don't have. I like to think about what I have, and we don't have renal replacement therapy. We have peritoneal dialysis. Mm-hmm. So my question to you is, do you worry about fluid accumulation before the patient reaches the indications for renal replacement therapy? Or you just wait for them to reach the indications and then start renal replacement?
So, I mean, there are two main indications for renal replacement. One is that you have massive fluid overload, which usually is iatrogenic. So that's something, if you're aware of this, you can control this in the 24 hours before. And the second one, of course, is that your renal function goes off because you have AKI and your renal perfusion has been really, really poor, right? In the second case, you may get through allowing a few more days for the kidney. Septic shock, always in kids, these kidneys almost always recover, right? Or you use PD unless you have contraindications from the tummy, yeah. But I think the time pressure to go on renal replacement early usually comes from fluid overload with then respiratory compromise. And so this is why I think if we're more cautious about fluid, potentially actually we can reduce that time pressure, and then PD, waiting or PD can be much more viable, yeah. And it's not that easy to put these kids on a filter in the first 24 hours. Usually they're coagulopathic, they're hemodynamically very unstable. Even if you put them on, you can't pull off much fluid. It's not that easy. And usually it's not a time where almost never do you need to go on because of potassium or acidosis. So yeah, it's mainly the fluid.
Obrigada, Lunig. Obrigada, pessoal. Foi excelente.
Obrigado a vocês.